What if the way we measure a doctor's productivity is completely wrong? Not just a little off, but fundamentally, structurally, irreparably broken. The common story is that we're fixing healthcare with value based care, paying for outcomes instead of volume. But here's the thing. After 14 years and billions of dollars, frankly, this hasn't worked. In this video, I'm going to share something I haven't seen anyone talk about yet, and I think it's an idea that could reshape how we think about healthcare delivery. First, I'll show you what's happening right now in software development, where companies are setting mandatory $1,000 a day AI budgets for developers and measuring their output tokens. Second, why the RVU system that really runs healthcare reimbursement today is a volume treadmill that's burning out physicians and really rewarding the wrong behavior. And third, the part I'm most excited about, what happens when we apply this same token-based measurement to clinical care? Not how many patients did you see today, but how much agentic activity did you perform to improve your patients' lives? Here's why this matters right now. Medicare physician payment has declined at least 26% since 2001 when you adjust for inflation. The AMA declared MIPS, the Quality Measurement Program, broken and must be replaced. That's their quote, not mine. The Congressional Budget Office found that CMS's Innovation Center's value-based care experiments actually increased federal spending by about $5.4 billion. Not saved, increased. Meanwhile, physicians spend 2 hours on work for every 1 hour of patient care, and burnout hovers around half of physicians in survey after survey. The system isn't just failing. It's failing at enormous cost to taxpayers, to physicians, and most importantly, to patients. Let's dive in and see what we can find out. So here's where this gets interesting. Let me take you outside of healthcare for a minute and into the world of software where something wild is happening. Companies are starting to measure developer productivity not by lines of code written, not by features shipped, but by tokens consumed. I'm hearing from multiple sources that AI-forward companies are setting mandatory budgets of $1,000 per developer per day in token spend. Peter Steinberger, the creator of OpenClaw, we've talked about that before here, is spending $10,000 to $20,000 a month out of his own pocket, running 6 simultaneous coding agents. Satya Nadella says 30% of Microsoft's code is now AI generated. Sundar over at Google says that 25%. Dario Amodei, who's the CEO of Anthropic, predicted 90% of code would be AI written within months. And here's the key part that most people miss. The old metrics, the lines of code, it's actually dead. Nobody seriously measures developer productivity by how many lines of code they typed anymore. It's about outcomes, what shipped, what problem got solved, how did it go from idea to production. Greptile, which is a company that does code reviews, State of AI Coding Report, showed that median lines of code per developer jumped 26% in 1 year. PRs got 30% larger. But GetClear found that code churn, that's code written and then immediately rewritten, went up 4 times. So more output doesn't automatically mean better output. The token is the unit of AI work, Jensen Huang's words, not mine. But what matters is what that token produces. The shift here isn't from one vanity metric to another. It's from measuring human keystrokes to measuring AI-augmented outcomes. Deloitte, PwC, and McKinsey are all now treating token budgets the same way companies treat cloud compute. It's a strategic investment line item, not an expense to minimize. Now, here's where it gets really interesting. The common story in healthcare is that we've been on a journey from fee-for-service to value-based care, volume to value, and we're almost there. But the reality, it's way more complicated. Let me explain what an RVU actually is, because most people outside of healthcare have no idea, and it actually controls everything. Every medical service in America has a number assigned to it. It's called a relative value unit. It measures 3 things: the physician's work, the practice overhead, and the malpractice risk. The number gets multiplied by a conversion factor. I think this year it's $32.35, and that's what the doctor gets paid. More RVUs equals more pay, period. The problem, this creates a treadmill. Physicians are pushed to see 20 to 25 patients a day. Procedures are overvalued 3 to 5 times compared to cognitive care, meaning a doctor who spends 30 minutes thinking through a complex diagnosis gets paid a fraction of what someone doing a quick procedure gets. And here's the killer stat. For every 1 hour of direct patient care, physicians spend nearly 2 hours additionally on EHR documentation and desk work. Family doctors spend 86 minutes every night after they go home finishing their computer work. They call it pajama time in the industry. The AMA found that MIPS compliance alone costs $12,800 a year per physician and requires 200 and more hours of administrative work. And value based care was supposed to fix all this. Pay for outcomes, right? Not volume. Reward keeping patients healthy. That's what we were all told. But the Congressional Budget Office looked at 14 years of CMMI demonstrations and found that only 6 out of nearly 50 models produced even modest savings. The CBO estimates these experiments increased federal spending by about $5.4 billion. Not saved, they actually cost more. The Center for Healthcare Quality and Payment Reform identified 20 specific reasons value based care deals fail, from mean reversion bias to financial gamesmanship. And Moody's found that for many rated hospitals and health systems, less than 1% of revenue comes from risk-based payment arrangements. Less than 1%. After 14 years, after billions of dollars in spending. 1%. I'm going to be honest with you. The RVU system measures the wrong thing. Value-based care promised to measure the right thing, but couldn't deliver. And right now, 93% of physicians say that prior authorization delays patient care, and 89% say it contributes to their burnout. We don't need a better version of the old system. We need a fundamentally different way of thinking about what clinical productivity actually means. So what's the problem? Now let's talk about what might actually work. The part most people miss about AI in healthcare is that everyone's focused on the wrong use case. They think about AI writing clinical notes, which is great. Ambient scribes are saving doctors hours per day, but that's just the beginning. The really transformative thing isn't AI doing documentation faster. It's AI doing clinical work that humans literally cannot do at scale. Imagine this scenario. A physician has a panel of 2,000 patients. Today, they see maybe 20 of those patients in a day. That's 1% of their panel. The other 99%, they're out there living their lives. They're possibly missing medications, developing conditions that could be caught early. They're possibly on a treatment that a newer study shows isn't optimal anymore. In the current RVU system, there is no incentive, zero, for that physician to proactively review their entire panel. You don't get paid for it, there's no code for it, and it doesn't generate RVUs. But what if we measured something different? What if instead of how many patients did you see today, the question was how much agentic activity did you perform to improve your patient's care? Here's what that looks like in practice. An AI agent scans your entire patient population overnight. It identifies 47 patients who missed their statin refill. It flags 12 patients whose A1C trends suggest they need an intervention before they become diabetic. It finds 3 patients on a medication that a new meta-analysis shows has better alternatives. It surfaces all of this to the physician in a prioritized dashboard. The physician reviews, approves, modifies, human in the loop, always, and the actions get taken. Secure messages go out, prescriptions get updated, referrals get initiated. The physician just delivered more preventative value in one morning than they could in a month of 20-minute office visits. But under the current system, they generated exactly 0 RVUs for that work. Now think about the parallel to software. A developer using AI agents isn't typing more code. They're orchestrating systems that produce outcomes at scale. The token is the unit of work, but the outcome is what matters. The same principle applies here. The token, the agentic activity, is the unit of clinical AI work. But what matters is the outcome. Disease prevented, medications optimized, gaps in care closed, lives improved. Here's what I think needs to happen. And I know this is bold, but stay with me. Systems that leverage AI to accelerate quality, efficiency, and patient outcomes should be reimbursed better. Not the same, not less, but actually better. Why? Because it aligns incentives for the very first time. Employers and payers, the people who are actually writing the checks, they want 3 things. They want better outcomes, lower total cost, and better patient experience. An AI augmented practice that proactively manages the entire panel delivers all 3 of these. If you reward that practice with higher reimbursement per episode, the total cost of care still goes down because you're preventing expensive downstream events. Fewer ER visits, fewer hospitalizations, early cancer detection, better medication adherence. The provider wins because they're rewarded for delivering higher quality, more comprehensive care. The employer wins because total spend decreases. But really important, the patient wins because they're actually healthier. Self-insured employers, and there are a lot of them, have the strongest incentive to pioneer this. They bear 100% of the claims risk. An AI augmented provider who prevents a single hospitalization saves them tens of thousands of dollars. If you only take away one thing from this video, let it be this. Gone are the days of how many patients did you see in the clinic. The question should be, how much agentic activity did you perform today to improve your patient population's health? The RVU is an analog metric for a digital world. Tokens, agentic clinical activities are the new unit of healthcare delivery. And the organizations that figure this out first will have an enormous advantage. So let me pull all this together. The software world is already measuring productivity in tokens, with companies investing $1,000 a day per developer because the AI augmented output justifies it. Healthcare is stuck on RVUs, a volume treadmill from 1992 that rewards procedures over thinking, ignores 99% of physicians' panel, and has contributed to burnout rates hovering around half the profession. Value-based care was supposed to fix this, but after 14 years and billions of dollars, the CBO says it actually costs more than it saved. The answer isn't a better version of the old system. The answer is a new metric entirely. Agentic clinical activity. How much AI augmented care did you deliver? How many gaps did you close? How many patients did you reach who would never have walked through your door? For healthcare leaders and employers, this opportunity is enormous. The system that adopts AI augmented care and build reimbursement models around it will attract the best physicians, deliver the best care outcomes, and spend less per life. The risk, clinging to RVUs and waiting for value-based care to finally work after 14 years of evidence that it won't. If this resonated with you, subscribe for more at the intersection of AI and healthcare. And if you want to dig deeper on this, including all the research and statistics and the frameworks I reference, get a full write-up on my Substack, links in the description. Thanks for watching. I'll see you in the next one.